All right, let's kick things off. Welcome everyone to today's webinar. The focus is on outperforming at any scale, achieving STAR's success at small, mid-sized, and newer MA plans. So all about how the best performing, smaller, and newer plans work their magic and how they make the most out of the unique advantages of smaller and newer plans and how they overcome some of the inherent challenges of smaller and newer plans. Before we dive into the content, some basic housekeeping. So we want this to be an interactive session. Please feel free to ask any questions you have. There is a Q&A box, or just put it in the chat box. We will be checking that as we go. We will answer questions, try to make it organic throughout the conversation. If a question is relevant to what we're talking about, we'll answer it. If it takes us outside of the flow of the conversation, we do have time at the end to answer those questions. So we'll try to get through all the questions as much as possible. There will be a summary and recording of this webinar posted on the Lilac website. That'll be sent out usually within 2 business days. You'll get an email notifying you of that. So you can take notes. We encourage taking notes, but there will be a summary, and the recording will also be made available. And then lastly, your feedback is super helpful in making these sessions as useful as possible. Please let us know how we're doing. Please let us know if there are topics you want us to dive into. The surveys are anonymous, so be as critical as is appropriate. We appreciate all the feedback that points out what we can do better. All right. Let me introduce our illustrious panel. First, we have Neetu Rajpal, the co-founder and CEO of Lilac Software. Neetu was the CTO of Oscar Health prior to founding Lilac. She has a lot of experience building enterprise software in a lot of different contexts. Spent a lot of time at Microsoft. She has a few patents under her belt. Just an expert in working with lots of unstructured data, making them, turning that into useful systems, whether that's analytics or now increasingly agentic AI. So a great perspective to bring to this conversation. Welcome, Neetu.
Thank you, Alex. It's great to be here.
Next, we have Mark Ryan, also a co-founder of Lilac and our Chief Solutions Officer. Mark has extensive experience in healthcare in a lot of different areas under the healthcare umbrella. Previous to Lilac, he was the president of MHK, which was MedHawk before. Mark has started health plans, so he brings a very unique and very valuable perspective in when looking at newer plans in particular. So Mark has taken a lot of roles across all the different areas of the healthcare ecosystem, from technology providers to starting and building health plans, and then also has done a lot on the policy side. Mark is also he runs a blog called The Healthcare Labyrinth, which also has a very high quality podcast for you to check out. So brings really, really deep expertise in all things health plan operations and health plan compliance. Mark, welcome.
Thanks very much, Alex.
And then rounding us out, we have Dwight Pattison. Dwight has 25 plus years in healthcare quality. He has led HEDIS operations at large and small health plans, so he understands the difference in context between what the big plans face and then smaller plans. Dwight has led professional services organizations at different providers, and he has been an independent consultant for a while, and we are very fortunate to get to collaborate with him. So welcome, Dwight.
Thank you.
Great. So give me one. There we go. So before diving into the open discussion, we want to share some of our data and analysis around the performance and some of the sort of specific areas of high performance and low performance for different sizes and ages of health plans. And obviously the content of this session is focused on small and mid-sized plans. So we're gonna unpack some of our findings in those areas a lot more throughout the course of this conversation. But you see that the thing to underscore is that the smaller side of the spectrum, it is hard to perform well. And so there are plans that are achieving higher performance, but it is challenging. There is a specific context that makes people's jobs in stars leaders in smaller plans simply more challenging. And the purpose of this session today is to talk about those and unpack specific tactics to overcome those challenges. And then the other lens to look at this data through is the age of plans. So we looked at plans that are quite young, under 5 years, and then 5 to 10 years, and then over 10 years. And then the last column is just the baseline of all plans. There's obviously the younger plans, similar to the smaller plans, have significant challenges just due to the nature of being younger, less mature, less resources. And interestingly, that's the 5 to 10 year plans, which probably have adopted some of the innovative practices, don't have as much organizational inertia that needs to be overcome to adapt to all the changes to stars. Those are the real top performers. And then the oldest plans, there's a dip back in performance. Again, there's just a bigger, deeper ingrained processes that are harder to adapt and harder to adopt innovative technologies and just figure out what needs to be done better as the star paradigm changes. Let me pause here for a second, just open it up to the floor. If anyone has any comments, anyone wants to have any observations that they think the audience should be aware of.
I think there's one takeaway, particularly with the idea of new plans, is it's also the same for new measures. So I want you to always think about the idea that ideas and strategies take time to implement and become sort of in fruition and an impact on members and their experience. So what I often see is when a new measure comes in play, like you need to sort of work early, even if it's like a plan measure that's like suggested. You want to have ideas and strategies, education with their providers, and that way it builds up over time. And the same for new plans, like they have to jump in and like resolve their challenges of provider education, their communications with the members. It's the same for new measures for all plans. So I think one of the takeaways I'd take is that whatever strategy you want to implement, it does typically take a cycle of time and measurement to get a hold of your performance. And then think about that when you know new measures are coming in a year or two, how much investment you've put into that now.
Great point.
Yeah, and just to reflect a little, Alex, that much of this data sort of is pretty consistent over the years. If you think about the breakout by tenure as well as the breakout by size, in certain years, if high performing, the largest plans are performing well, it skews a little more upward to the high plans, equaling maybe the middle-sized plans. But generally speaking, we always see that the 5 to 10 year tenure and the plans that are 50 to a couple 100,000 generally have the best performance over time. And I think that is a good, strong message to smaller plans, because as their enrollment grows and as they become more sophisticated and have more tenure in the program, you sort of graduate into that middle. And just think of it that way, because the performance stats throughout the year certainly support that.
Yeah, absolutely. That's a great key lesson for our attendees. Thank you, Mark. Let's continue on. And there are a few slides where the intent here is not to go over in this session. As mentioned, we will share all the materials as a follow-up. But we listed out the lowest performing measures and the best performing measures in each of the categories, both size of plan and then age/tenure of plan. And there's a few slides that go over each of these. The themes that we are seeing are the smaller plans, as you might expect, they perform well where in the types of measures that relate to basically the affinity of members. They have lower complaints, they have lower churn rates, But they also, on the other side, they have more challenges with things like medication adherence, drug measures more broadly beyond just medication adherence, and then care-related measures. The bigger plans, it's tends to be the opposite. You can see there's the worst performing plans. It's around the member, how much they actually, what I'll describe as the affinity for the plan. There's higher churn rates. The operational measures tend to perform lower just because they're big sprawling organizations. But then on the other side, the measures around member care and medication adherence do score higher. They just have more resources, more infrastructure built out to support those types of initiatives. We'll share these, and you can look in greater detail when you have more time to review these. We'll also share some supplementary material, but we want to give just this lens of where the younger plans are performing well, where the sort of, let's call them the older plans, and then the same type of context with small, medium, and larger plans. And what this amounts to is, the distilling what are the advantages of small, mid-size, and newer plans. You have a smaller membership base that you can build a tighter sense of community and build better relationships with. You have a smaller set of providers and other partners to reach members through. It's all just a much more manageable universe of entities that you need to interact with. There's a smaller geographic coverage. You don't have to worry about the complexities and reaching lots of different parts of a huge coverage area. And then, one of probably the biggest things is just organizational agility. You can move faster, you can make decisions. You don't have as much built-in organizational, just the process and structure that tends to slow things down and make health plans in any organization just be less responsive. On the flip side, fewer people resources across the board, less centralized resources for planning and strategy, less resources for doing outreach and member engagement. The data infrastructure not as built out, not as mature. And this is probably different plan to plan, but just generally less awareness about the STAR program and what it takes to be really successful. So there's more education that's needed. And then the last thing, and this is really goes, it's both a positive and a negative, where if you miss on a few members, your measures are your member-based measures, HEDIS, medication adherence will move really quickly. At the same time, there's more opportunities to just move things up as well. So the denominators are smaller. That means that movements in either direction are going to move the overall the score for that given measure a lot more easily and a lot more quickly. With that, we're going to open it up to conversation around given the advantages, given the disadvantages, given the context of smaller plans, what do our attendees and what do smaller plans need to do in order to, let me stop sharing my screen, to perform really well. And Mark, I'm going to start with a question to you around just a really core part of STAR program management and everyone's favorite piece of technology in the HEDIS vendor. What is it that small and mid-sized plans and newer plans need to do in managing the relationship with their HEDIS vendor in order to put themselves in the best possible position to perform well in STARS?
Great, Alex. Let me cover the new plans first, because I think oftentimes new plans believe they sort of don't have to worry about STAR from the beginning because they are going to get a new plan rating that goes into the rate setting system. And I think plans really have to understand that from day one, literally, a lot of your performance will go into a future year STAR rating. And so think about the lag in HEDIS data, think about the lag in drug data and things like that. But that data, even from day one, will likely impact a future STAR rating, right? And so that's really important. You really have to be focused from day one on doing all of this correctly. Your HEDIS data from day one, your drug data 2 years down the road can impact your star rating. You are going to get a CAP survey pretty quickly, and how you perform with your members in that first year is going to be important to success there. The same thing with Haas, and then even on the operational measures, we know that those statistics are starting to be gathered immediately, right? So don't think of that as 2 years of not having to do anything. You really do have to start and have a strategy right from day one, and you have to align your folks on that. On the HEDIS vendor front, I think many plans are reliant on their HEDIS vendor. Other plans are adopting technology similar to Lilac that will also be used potentially to help improve. But I think if you are relying on your HEDIS vendor, there's a couple of things to really remember. Number one, is that HEDIS vendor supplying you with enough runs throughout the year so that you have a good understanding of where your improvement in the current measure year is and how to move it forward? Number two, what is that data lag? Because the data lag can often really hurt you in terms of how you can improve. So have as minimal a data lag as possible within budgetary constraints, have as many runs as possible so that you can get a really good, honest picture of what you're doing, how you're doing. And I think the last point I'd make on this is that the star measurement is getting much more complex, right? So that HEDIS vendor might also really have to start to give you more granular data so that things like EHO for all calculations can be done and improved upon throughout the year. So if your HEDIS vendor isn't doing that, there are other vendors out there that can sort of speed the process of analyzing performance, provide better data frequency and better reports. But if you are relying on that HEDIS vendor, that's really, really important. I'd also note on really quickly what I call the event-based measures: readmissions, transitions of care, and follow-up ED. These are very tough to perform on, and you absolutely need an ADT strategy and working with your providers to make sure they're receiving the notifications and you are working those 7-day and 30-day events all the time. So just some quick thoughts on what to think about as a newer plan for how you think about those clinical measures.
Got it. That's really insightful. And the event-based measures, those are some of the most common poor performing measures in the mid-size and small plans. So what you're saying bears out very much with the data. I'm going to take that and go to an adjacent topic. A question for you. In terms of actually engaging members, small and mid-sized plans, they obviously by very definition have fewer members to go and engage, but they also have fewer resources available to reach those members. From someone with a technology lens, thinking about how do you optimize scale, how do you optimize efficiency, what is it that these small and mid-sized plans can do to reach their members in as personalized and as precise a way as possible for sort of overall member satisfaction, but also for driving, measure performance for overall star ratings benefits?
Yeah, thank you, Alex. So the plans we talked to that are small and medium-sized plans, they tend to have obviously fewer members than the larger plans. And it's always very attractive to say, I have few members, so I can just call everyone and reach out to everyone. And that is actually true. If you have fewer members, you can reach out to everybody who falls in a measure. But what we find is the person who's in charge of reaching out to all the members is likely spending hours, days, or weeks collating the list of members, identifying what prior conversations they've had with the members so they can make sure to have the right conversation next. And as the number of measures that the member may fall into grow, the coordination between do I reach out to this member for 2 measures, 3 measures, 4 measures, or 5 measures? That gets very complicated. And as of right now, we live in an amazing time where there is technology available pretty much like close to off the shelf that can help with managing the information about all of these members. So I am talking about AI agents that understand the data, that understand the models, that understand member history, and on basically on the fly, I can tell you this is the recommended strategy for reaching out to this member for these set of measures in this way. And that you can do like what used to take like hours, days, and weeks can take like minutes, if that. So that I think is like an amazing thing. That's just the immediate value of using agentic AI to collate the data before you reach out to a member. There are a couple other benefits that are currently available, which is all of this data is now in one place, so you can have a pretty comprehensive view of what the member is experiencing, what they have interacted with you in the past, and what the right way to interact with them next is. But in addition to all of that, anytime that we've talked to plans, they tend to prioritize high value members, and they almost they struggle to get to the low risk members. But with agentic AI, you can in fact automatically have voice agents reach out to the member directly, and you can reach literally your whole population for all cases. And further, as you grow the amount of data that you will have about each member, you have probably this data, and the plans we talked to have this data in spreadsheets like spread across and not in one place, which means they have complexity of measures, the number of years that the member's been with the plan, that gets very complex. So being able to collect history over time, so you have a continued relationship with that member, all I'm arriving at is when you're a small plan, you have the option to start building a base for having a member-centric view of every measure and every outreach. And you can use agentic AI for not just the data piece, but also the outreach piece and overall history piece as well. So I highly, highly recommend, taking advantage of some of these like new technologies that are currently available. And a large number of them can be like fairly economical at this time. So happy to help you as part of Lilac, but also just happy to just share insights and help in whichever other way. But yeah, there's lots of great stuff available now to keep track of all of this information. Highly recommend it.
Need to. I think that's really exciting. I think people don't realize how important it is to consider these new tools and integrate them into their plan. So there's a time where you need a nurse to talk to a member or a pharmacist, but they can never, even if you're small or medium, like there's never enough people. So using like strategies that like text for these members, agentic outreach for others, like, and then direct member engagement is for those that you can really serve. And I think there's a real win if you can start imagining this as a supportive role, not a replacement role in your quality strategy. And I think that's pretty interesting.
Yeah. Thank you, Don.
Yeah.
Yeah, and tie it back to small and mid-sized plans being more agile and being able to look at the new age tools and having less organizational complexity, less layers of really established process where you can just move faster and leverage these things that are coming out. It is a very exciting time with the agentic AI is improving so quickly that it is making things possible now and in the very near future that simply were not possible to do in terms of member engagement, in terms of just, as I said, like the tedium of collating data that sits in lots of different spreadsheets or systems, which is how most smaller plans tend to be configured. It can be a real game changer. So let's build on this topic, and Dwight, I'm gonna go to you next. Don't want to if you thought you'd be unscathed, and I'm here to disappoint you. So let's talk about CAPS and HOS, and what smaller plans do. They're closer to the members, but can't take member satisfaction and can take performance in CAHPS and HOS surveys for granted. What can small and mid-sized plans do and newer plans to really best shape CAHPS HOS scores?
All right. So I think I have about an hour to talk, right?
I think
So let me say, the big guys, because I worked national plan, would have individuals or teams accountable for just CAHPS, right? So they're focused. When you're small, agile, and medium-sized, like you're wearing multiple hats. And what gets challenged with CAHPS is this idea like ownership is a problem, confusion, like of what it's mean. So I want you to break down this. CAHPS is a methodology for collecting information. The measurements you're concerned about are very different. So you're going to want ownerships and teams and activities that dive into access to your providers and specialists, customer service response, and then CAHPS. There's certainly strategies globally on like how you get better response rates and the like, but I want you to think about that first and foremost so that you have the right projects designed. It's not that many, but it would certainly want to be divided. You can also use your quality committee to integrate your strategies for that. But for CAHPS and HOS in general, what I want you to think about is we don't get enough on, I'll get to HOS in a minute. With CAHPS, there's this push to do like this mid-year resurvey so that you can measure how you're doing. And I'm a big fan of measuring and tracking so you can improve your score, but you don't have to spend that much money always to like re-examine what you know about from your last CAHPS survey. They don't change that much. And oddly, your mid-year doesn't always predict your score in the end of the year for some reason. So what I like to do is more broader based surveying of individual questions or chances to gather and identify members of need and recover, so they call it service recovery, versus those that are average feeling. Because actually the biggest population that you actually need to engage is the unengaged and the members that feel okay and don't complain, but need to be like rating you instead of a 6, you want them to rate you an 8, right? So those kinds of ideas, I was like, how do we compartmentalize and identify? By doing pulse surveys, using Nitu's idea around agentic outreach, quickly gathering data on members as you go. And you can even do this through department staff. So like if anyone who calls a member, you say, before I hang up, if you wouldn't rate us a 10 out of 10, what is the issue you need resolved? And you take that and you run with it and you help that member with the resolution through some engagement or escalation process. So gathering member level information so you can engage on that process. The same is for HOS. And I'll just say that with HOS, there is 6 weighted points for the improving and maintaining health status. You need to start tackling that through member outreach, engagement, and you can use claims data analytics, agentic outreach, pulse surveys to find out who's depressed, who has changes in social status, who might have issues that are new medical changes that might require new DME, new concerns. Maybe they're less able to walk. Maybe their ability to go shopping is different. How do you know that information without engaging with them? It's HRAs, it's pulse surveys, it's case management programs, it's population health-based programs. That sounds expensive, but I think you can create some efficient ways to start targeting and identifying tracking your members through modern means so that you can then identify who needs help, because those measures are often variable and they're high points. And I think people often miss addressing them through they don't know how to do it. And I remember when these measures were in STARS like 5-6 years ago, and everyone would say, well, we do an exercise program, or we have this thing, and they want to check the box and say they're doing something. The effective efforts for these populations is truly engaging on those members that need help or are slipping through the cracks of the system and not getting to the access and service they need. So you think about getting members to the right community services, to the right providers, and linking them to those kinds of efforts will help make them live better, feel better, report better those surveys. And that's a challenging idea, but it's going to help your organization's performance overall with retention, member compliance with patient recommendations, just general health status. So if you can deal with these things that are measured in HOS and CAHPS, that will help your operations in general. There are so many benefits to that. And so the ROI and the requirements of investment can be built out of retention, cost of care, et cetera, through the strategy you need to do. And I really hope you sort of map that work out because it's worth it, worth the effort, and the broad spectrum impact is meaningful. So that's my take.
Can I just jump in real quick there, Dwight, and Alex, and need you to underscore something? I think Dwight's points are amazing. When I think about just the weighting, as Dwight alluded to, you have the two improving Haas measures at 6 points. And remember, at one time, caps were up at 4. They're now 2. But even if you go 2 weighted on each of those cap measures, plus the 6 weights on the 2 improving, plus a few more on the Haas side, you are really looking at, I'm going to just round it to about a quarter of your performance is tied, or maybe more, to doing well on these survey things. It's hard in many plans, especially younger ones, sort of say, well, I don't understand it. I can't really tackle it. Let's just assume I'm going to perform the same I did last year. And I'll go concentrate on drug measures, HEDIS measures, and things like that. But that's going to be a barrier to achieving high performance. So you really have to get that strategy together. And as Neetu and Dwight pointed out, agentic systems, not full mocks, things like that, you can devise a reasonable strategy that actually probably has a greater return on investment than maybe some other measures because they're so heavily weighted if you can impact them.
Plenty to talk about there.
Yeah, great points. Could be its own webinar, I think. So as we're talking about this member engagement, someone asked the question, does Lilac support AI technology to prioritize members for outreach, method of outreach? Are these products currently available on the market with data support, efficacy? The short answer is yes. We're doing a lot with agentic enabled outreach, both in terms of the collation of data, just streamlining the workflows to enable people to do outreach, but then also integrating voice agents in to do the outreach itself, trained for specific use cases. But Neetu, this is a bit of your baby, so maybe pass it over to you, and if there's anything you want to add to that.
Yeah, so like Alex said, we definitely have agents that can monitor your stars performance, make recommendations, prioritize. We have a solution for actually collating the data, doing the outreach either by a human or by a voice agent. But we're going a bit step further where, there's lots of clinical literature now available for what is the right way to engage members, for example, for medication adherence. So we've actually built models and models and agents that can like look at member history, look at member demographic information, identify members that are most likely to close a gap, that are most impactful to close a gap, identify the high risk, low risk, and medium risk cohorts, and then make recommendations for the right ways to outreach to those members and do the outreach where appropriate. We tend to stay away from any outreach that is clinical. We stick to administrative outreach. Any outreach that should really be done by a pharmacist or a medical professional, we actually pass it on. But all of the other pieces around reminding, identifying barriers, caps and Haas, like Dwight mentioned, pulse surveys, identifying if who needs a transportation service, like scheduling that transportation service, or identifying who needs to move to a 90-day prescription refill versus a 30-day one. Those are all. We've gone as far as building the whole health risk assessment survey as well as a voice agent, and that's also available right now. So we have lots of bundles that are in the works, a few that are already working now. So if you or anybody in your team is interested in partnering, we would love to partner. So just reach out.
Yeah, thanks. And we'll, in the follow-up, maybe we can mention some actions if that is of interest. Okay, so segueing to the next topic, which is related to medication adherence, one of the areas that we've just talked about, and another big important vendor relationship. The PBM, obviously, hugely important and it touches star performance in a lot of different ways. Mark, you have a lot of experience working with PBMs, both as a technology leader and as a health plan operator. I'm going to pose the question to you: as a smaller, newer plan, what do Stars leaders need to be doing with their PBM relationship to put themselves in the best position to perform well for Stars?
Sure. Thanks, Alex. So I'm going to approach it a little bit like I did with the HEDIS. I think you have to ask your PBM, which oftentimes for smaller plans are taking on the responsibility of helping you drive performance on these star measures. What are they really investing in you? And I would say that generally speaking, there are probably 2 or 3 flavors at a PBM, and part of that third flavor will be some other vendors, sort of like Lilac, that are investing in very robust engagement and analysis of these drug measures with really real-time data. So the first flavor, unfortunately, and oftentimes plans don't really know this until they get into the relationship, because when you're setting up a new plan, you're sort of capturing a PBM and you maybe not even ask about what star support do you get. But that first flavor is very vanilla support from the PBM. And largely what plans are doing are relying on the acumen reports that come out from CMS. And we know that there are a 90 to 120-day lag in those reports. Your first report comes out in April, and you've sort of given up about a third of the year already before you really know how your members are doing on adherence and the other measures and things like that. So that first flavor is not a lot going on with PBM support for you there. I think the second flavor is somewhere in the middle, where the PBM does have some reporting. They pull back the lag a little, but there's still a lag in there. And they may not be really, they may or may not be using the PQA measure and saying, this is how you're doing, for example, but they are giving you some support and giving you a feel for where your members are non-compliant and things like that. That's better, but probably not where you want to be either to get to excellence. The highest performing PBMs and vendors like Lilac are giving you no data lag. They are running your data on a daily or weekly basis, depending on the measure, to give you a very clear picture about where you are. Number 2, through agentic and other analysis tools, they are giving you why somebody is non-compliant, what the potential propensity is to close that member's gap and things like that. And they've really built in every algorithm, CMS and PQA and HEDIS, into their formula. So it's very, very accurate. And the chase lists that are produced, again, are very little or no data lag. They're giving you things on a daily basis to find out if there's a refill due for a member and whether it's overdue, to allow you to either agentically or through an IVR intervene, or escalate it to a call center to reach out and ask what's happening. They're also helping you track your PDEs, right? Because PDE submission and accuracy and remediation is very, very important. And they're also reconciling the CMS and plan data. I can't emphasize enough that there are errors that are made by CMS, and those can be found and they can boost your performance during that closeout period. On the new measures, poly-ACH and COB, it's not enough to be looking at who's non-compliant, because by the time you get into what I call the negative numerator, you're already non-compliant for the year, right? You need to really look at who's at risk of going into that numerator and have that data available to intervene with your providers in this case. I would also note that you need to engage providers and members depending on the measure. And lastly, I think trying to understand their barriers are key. As we talked about, there are financial considerations, there are transportation and other considerations. So agentic or a verbal call outreach can identify those kind of things that you can document and track over time and remediate over time as well. Those are really, really key issues that are really making high drug performance very, very difficult right now. And we know they're among the lowest performing measures.
Yeah, Mark, I just was going to say that the number one question I get from small and mid-sized plans is, what do I do about adherence? And I just reiterate the fact that measuring, tracking daily, weekly, and then actually you have to have teams of people or agentics and supportive work connecting and getting members to fill those prescriptions before the gap becomes too large, and starting early in the year. So it is not a one strategy fits every member. It takes work all year round, and the data supports that is going to have to be there to support it.
And just one thing here, if I remember my Oscar days, early on when Oscar didn't have as large a membership, we did not get a lot of attention from our PBM. And as our membership grew, so did the attention we got from the PBM. So as a small plan, I think you're actually probably at a disadvantage to getting to this chase list on the drug side.
Yeah, and that's a good selling point. Generally, as a smaller plan, you're probably not getting as much love from a lot of the big vendors in general. And so you need to find ways to make up for what a lot of bigger plans are getting. All right, we're getting close to time, but there's one more topic area we wanted to touch on in regards to operational measures. They're 2x weighted. Dwight, why don't you round us out and just talk about what are some of the things that smaller plans need to do with operational measures?
Track. Here, the numbers are so small. I had a client that missed a 4-star rating by 3 appeals, right? So that one measure, 3 cases were sent in December. The manager, who I was doing a post look back assessment of the plan. The manager pulled me aside and says, well, I told the medical director we shouldn't have set these cases in. He was adamant that day. She said he was grumpy that day, and he would send them. And so I would say with appeals, you need a team that reviews cases to make sure you want to make the decisions you're making. But it's now, I used to say, it's like you have very room, now you have to be at 100%. So it's literally understanding from day one that the expected scores for these standard measures, operational, are so high in performance that what people are doing is daily tracking, weekly notification. The minute a case fails in appeals, in telephone monitoring, et cetera, or CTMs come in, a team is on it. And that's where you have to have like an escalated process where it's like, we cannot afford one mistake, let alone 2, 3, 4. So the minute something happens, everyone needs to understand that the resource and effort of that is critical. And that's the big difference on that. And so, it's not easy to have goals of 100%, 99%, but that's currently the competitive nature of those measures. I will say, keep your eye out. Here's a trick, is that CMS proposed eliminating the operational measures. And so what you really should be doing as a STARS leader or a group of people concerned about STARS is modeling your scores overall based on predicted changes or suggested changes. It doesn't mean it will happen. It means that they're thinking about it. And if they just do it immediately, you might find yourself doing really well on those, and you need to do better elsewhere. So STARS strategy, whether it's operational or others, is about understanding what's coming and how those score changes will impact your plan, and adjusting quickly so that you don't pre-assume that the thing that was there before is going to be there in the future, that you're ready for new measures like Mark mentioned, polypharmacy measures, that plans are still struggling in their first year to actually implement strategies in fourth quarter. So planning ahead and measuring that impact is one of those things I'll recommend.
Yeah, could I just,
Please.
one other thing I'd add to what Dwight said was, make sure even post year end or throughout the year for sure, if you can, look at your data, because we have found situations with our clients where call center could truly be challenged, and CMS will admit that they scored you wrong on that call, right? Now, we know that there's high-profile lawsuits where CMS has won, but it's also true that there are calls that are misclassified, that are not the plan's fault, that are scored against them, and you can undo that during plan preview or before, potentially, right, on some measures. Appeals as well. There could be misclassifications. We will tell you that if you send in, as Dwight pointed out, that's sort of a bad thing and it's used against you, but you can also say that perhaps that shouldn't have been submitted, and that can be reduced from your count. CTM misclassification in the plan preview data is a big issue. You can look at whether they are CMS issues and they weren't pulled out by CMS, or whether they're other plan issues. So really scrutinizing your data throughout the year, but especially through that first 6 months and into plan preview, is another very important strategy that can mean the difference potentially between a rating.
Yeah, I'll reiterate that too, is that HPMS memo comes out from CMS with deadlines for data validation. So like you have a deadline to June to fix all of your pharmacy data in PDEs, submissions to CMS. Any measure that's scored by CMS, you should be auditing live as you go. And then they have deadlines for correction. That doesn't mean you can't address it through plan preview. But I know a plan that found data errors in July in their pharmacy data, and CMS said, sorry, too late. You read the memo, it said it was due by June. So definitely understand the deadlines for that as well. But clearly, through plan preview, you're going to put forth the best foot. And we've, Mark and others, we've all worked with plans that have fixed problems through plan preview cycle. But you have a long period of time that would be worth looking at the quality of those results.
One last tip, everybody should look at the leave numbers because of the new, and this is dependent on your profile, your population, or where you are in the country, right? But there are new exceptions related to disenrollments where members go to other somewhat integrated or fully integrated SNPs, right? It's not counted against you. So you probably noticed in Star Year 26 that your leave statistics looked a little different because of the addition of that exception. It just started, and people should be aware of that and sort of re-benchmark their leave statistics, because that will impact your cut points and things like that in the future as well.
Good, very good.
Yeah, I think that's a great tactical place to wrap up. Thank you to our panelists. Appreciate everyone's great insight and great dialogue. Thank you for the attendees for joining. I hope this was a useful session. Again, please fill out the survey. It's really helpful for us. We will send the recording and notes, and then also the slides and some additional analysis from that was at the beginning of of this webinar. We'll post a few other blogs just looking at the data from a few different angles. And yes, if we can help you in any of these areas, please do engage, and we'd be happy to have an exploratory conversation around areas we can support you. Thank you very much, and expect to get a closing follow-up email in a day or two. Have a great rest of your week, everyone.
Thank you.